afternoon to you all. So as Dr. Preeti said that my job has become quite easy after Professor Kapoor's talk, and I have been given tasks to talk something about record keeping and clinical audit. So what I would be doing is first I would be talking about record and then I would be touching briefly upon clinical audit. So what basically is a medical record? I need not to tell you. This is basically collection of the data on a patient, including history, what is the statement of current problem, diagnosis, and treatment procedure. So whatever communication or intervention we do upon patient, that has to be recorded and that becomes part of medical record. So why do we need record? Just now we heard from Professor Kapoor that one of the important part of record is consent, and that has so many implications. And the same is true for any kind of medical record. So I need not to say that primary intent is to support our direct patient care. So it helps in this thing memorizing about patient's problem, then it helps us to communicate to the other departments and consultations with proper records. But however, there are equally important functions which your medical records serve. Like if we keep proper medical records, then being a teaching institute, it helps us in clinical audit and research. Because any medical record form basis of clinical audit and thereafter medical research. Then not only that, that's how we help the department by keeping proper record. But if you look from the point of administration, they would see record with the intent of resource allocation, service planning, performance monitoring, and when it goes to larger area, like if to state or national, then it helps in this thing, tracking down epidemiology of disease. And I think I need not to emphasize that is quite relevant in today's COVID era. But last, not the least, is medico-legal. And it is acquiring a huge proportion so far as today's times are concerned. So what are the aspects of record? So there are two major aspects. One is how do we enter the records or fill the records, but equally important is maintenance and keeping of record. Like resident, we are always bothered that our consultant or seniors are this thing hammering us for filling up records. But when you this thing slightly go to third year or you come in consultant post, then you realize that equally important aspect is ownership of the record, storage, retention, and if those have to be destroyed, how to destroy them. So I would be telling briefly about all these aspects. So when we are looking at any record, so there are four major broad components inherent to any record. One is administrative, second is legal, financial, and fourth is clinical. But these are not standalone components, and one is related to others, as is quite comprehensible. So what is administrative? Administrative is basically you want to identify the patient by this thing, age, gender, date of birth, or like we give a unique CR number in our hospital, then we need to have permanent address and so on and so forth. Then the second and equally important is legal record. So just now Professor Kapoor said, though it is very important for our day-to-day medical practice, but consent and authorization records are mainly for legal purposes. Then there are financial relating to billing of the patient, and last but not the least, that is clinical, which this thing we spend our major time in filling these records. And these clinical records could be inpatient record, outpatient records, then death summary and discharge summary. So now coming to entry in journal. So what we should be doing is that, needless to say, since medical schools And even if you look at the newspaper, everywhere it is being emphasized that these records should be written in a legible way, because doctors have been accused times and again of poor handwriting. So wherever you think that this is the important component, like diagnosis and prescription, and if you are not too sure about your handwriting like I am, so better to write in capital letters. Scribbling should be avoided at all cost. And needless to say that all the records should be accurate, up to date, placed in order, and complete in all respect all the time. If you have to alter some record, so do not obliterate the original entry. The best way is just put a line over the original entry, countersign it, and then put the new entry. And needless to say that we need to spend some time to prepare these records. Otherwise, we could not achieve perfection. So now coming to inpatient records. These guidelines I have taken from Royal College of Physicians guidelines, which were prepared in 2008, but these are very pertinent in our setting also. So coming to inpatient record, the record should be available at all time during a patient's stay in hospital. Every page in the medical record should include patient's name and identifying information, because in case if it slips from the file, then it would be easier to place those pages back in the file in the proper sequence and proper format. Then content of the record should be in standardized format. Like in our hospital also, we have certain formats for entering investigation report, inpatient progress chart, and nursing progress chart. So we should adhere to those formats, and because it's easier whenever a resident or faculty from other department come, so it's easier for them to go through those records if they are in standardized format. So whenever you are writing medication, it is advisable that we should be using generic name. And these records should be in continuum. Like yesterday entry should not come after today's entry. So there has to be continuum in the record keeping. Whatever record is there, that should be as per standard pro forma, as I told, and entry should be clocked. And ideally it should be a 24 hours clock, and whosoever is entering the record, he or she should clearly sign after entering the record, and besides that they should also print their names, so that could be easily referred to. Ideally all the entries should be made as soon as possible, but it does happen in practice sometimes, like a patient is very sick, you are busy in resuscitating the patient, but as soon as you get free time, you should be able to fill that record. If it is not filled, then the reason for not doing so should be clearly explained, because this is very important in cases, in medical legal cases. Then it is very important whenever entry is being made, the senior most team member's name should appear in the record. The person who is supposed to be making decision about that patient should be identified. And each time he or she visits, that needs to be noted down on the file. And if a patient is not very sick, you should be able to fill the records on daily basis. However, if you fail to do so, it should ideally be done within 4 days, or in cases of sick patient earlier. And as soon as patient get admitted, you should be starting to prepare the discharge record, because it is discharge summary summarizes all the events which happened during patient's stay in hospital. So it should be started from the day one. And in case of sick patient, advance directive consent resuscitations advice like DNR or do not resuscitation advice, etc., should be taken in advance and kept properly secure in the file. So in case of need, you can refer back to that consent or that authorization. So there is a manual uh, which has been brought by WHO, especially for developing country, and they have advised about record keeping. And according to them, the front sheet should appear like this, which I have projected in this slide. Basically, it should front sheet is almost like our hospital admission file, and it should reflect patient identity, then why the patient's diagnosis, why the patient was admitted in the hospital, and if patient was discharged or dead, uh, the reason for that, and at the last that it should be signed. Now this thing, as I said, the discharge summary should be initiated as soon as a patient is being admitted to the inpatient facility. So, and discharge summary should contain all the this thing information regarding patient's stay, uh, course during hospital stay, discharge advice, and if patient is dead, then in that case it would convert to death summary. And regarding discharge summary, one of my colleagues, Professor Gaurav, would be talking in detail, so I would skip this part. But the most important thing I want to emphasize is that even in cases where patient is discharged against medical advice, they are entitled to get a discharge summary, because it is an idea ingrained in some of ours mind that when the patient is being discharged against medical advice, he or she is not entitled for discharge summary. But it is not the case. So even in cases of left against medical advice, LAMA or DAMA, discharge against medical advice, we need to provide patient a discharge summary. So I need not to re-emphasize what I have told you just now. So I'm skipping that slide. But the thing to remember is for one patient, there should be only one identifying number or one CR number, and therefore only one medical record number. Whenever you this thing detect duplicacy during your stay, you should try to bring that thing to authorities on notice, because that can be, if a patient is carrying more than one identifying number, that could be misused. Now coming to filing or maintenance of the record. So it is our duty that we should be maintaining different register for different purposes, like for admission discharge register, for medical certificate, and so on and so forth. But most important among these, from physician point of view, is medical certificate. And for this purpose, each and every physician should, it is advisable by Medical Council of India as well, that we should be maintaining a separate register. Each certificate, as all of you know, should be bearing two identification mark of the patient. Each should be prepared in duplicate. So whenever you are issuing one, you should keep other as receipt of that medical certificate. Now, there is a question of ownership. Who owns these records? So needless to say, when we are in government facility, so whosoever our institute is the owner of the record. However, in private, there is no clear, so because there is no clear-cut legal advice or legal legal binding so far as India is concerned. So this is kind of gray area. But if you are doing private practice, you are the whole and soul in charge of that record. However, if you are attached to some corporate hospital, the management of the corporate hospital would be responsible or would be owner of that record. So, but wherever this thing you are, you should ensure that these records should be with authorized person, and you are responsible for confidentiality of these records in case you are involved in preparation of those records. So how long we should be retaining those records? So there are no legal guidelines, but remember, like consumer protection, under Consumer Protection Act, a case could be initiated 2 years after the event. So that therefore the Consumer Protection Act advises that we should be keeping these records for at least for 5 years. In cases of medico-legal nature, the record should be kept for at least 30 years and maybe long in cases the final decision has not been arrived at. And very important thing, like just now Professor Kapoor was talking about consent in cases of children. This is not a problem in our country as of now, but we are this thing at the cusp of new millennium. So we should be knowing that if parents give consent for their children, they might be held liable later on. So in cases of children, those records have to be kept till the children gain age of majority, that is 18 years in our country. So as I said, as of now, this is not legally binding on us, but we should be aware of about this fact. Then one of the most important part of record keeping is confidentiality. So we should be knowing where to share or not to share medical records. So we need to remember that medical records are not covered under RTI Act. So if a person is not related to a patient, we are not liable to give those records to that person, not even to patient's employer, not even to insurance company. However, we all know that courts have power to impound all the documents, and court can summon a doctor to provide record. That time we are duty bound to share the medical records. So, and it is very important to remember that if we share details or copies to unauthorized person, we may be charged for professional misconduct. And just now I said, even this thing case of Lama, patient is entitled for discharge summary. So you have to share that discharge summary. And whenever any death occurs, the death summary should be issued to next of the kin and within this prescribed time. And if the prescribed time by Medical Council of India in case of demand is 72 hours. Okay. However, we can share records for medical audit and research provided patient's identity is kept confidential and that is not revealed. Even if you have taken consent from the patient for sharing his or her record, make all the efforts not to reveal that patient's identity in any publication, conference, or workshop. Now coming to destruction of medical records. So how to destroy, when to destroy. As I said, like for routine cases which may fall under ambit of CPA, we have to keep records for 5 years, medical legal for 30 years. But like with paper records, the problem is that we would run out of the space very soon. So WHO has given certain guidelines that even when those records are being destroyed, we have to keep the front sheet, meaning thereby identifying information and reason of patient's visit or encounter with the medical facility. And in case patient was admitted, then a copy of each discharge summary should still be preserved. And when these are being destroyed, these should be destroyed under supervision, and burning or shredding is a better method of destruction of these records. So what you should do, I think you have a fair idea if you are this thing going, once you are going out of this institute, if you are on your own, you have to keep record under your lock and key. If you are with corporate hospital, then your burden would be less, but you have to ensure that these records could only be accessed by the authorized person and confidentiality should be protected at any cause. So, like all of us are bound by Medical Council of India, or now as it is called NMC. So Medical Council of India has come out with professional conduct, etiquette and ethics regulation. The latest was updated in 2002, and all those interested could find it on online on MCI website. And similar to whatever I have told, the MCI is asked to maintain record for 3 years, and in case of request, those should be provided within 72 hours. So where do we see problem? So there are certain areas where we should be more careful. So what are those potential problems? Usually this thing, as you must have read in newspaper also, courts now and then reprimand doctors to provide prescription in legible handwriting. So that is one of the important thing is, if we are giving handwritten prescription, that should be legible. And most important is signature and identifying information of the doctor should be very clear. So we should not only sign with date, but we should also provide our name at the end of the prescription. Then manipulated records come under this thing purview of CPA, and they um, are held against doctors in dispute redressal by dispute redressal agencies. So as I said, even if in case you have to make some changes to your records, you just have to uh, put a line over the existing record, countersign it, and then make a new entry. So now how does it happen? The perfection comes with practice. So corrective measure for all these potential problems is that we should make it a habit to fill record properly, and it could only be done if we try to invest some time in doing so. So please remember that these records are not solely needed for patient safety, but also your own safety. So whatever we have discussed, probably it was implied or not so implied that we were discussing about paper records. But in this era, and I would not say that this is emerging, but current trend is towards electronic medical record, or EMR as we say. So what is EMR? EMR is a real-time patient's medical record, and ideally it should be with access to evidence-based decision support tool that can be used to aid in decision making. Though not EMR systems have this thing, but at least we should try to incorporate EMR in all hospital. That has been advised by WHO as well. And I would not like to go what are the advantages that are self-evident, that it saves time, and if those are properly filled or interoperable EMR, once you fill EMR, you need not to write prescription, fresh consultation. Those records could be shared with your colleague with seamless efficiency. And as I said, that ideally these should come with clinical decision support system, or CDSS as it is said, or computerized provider order entry system, CPOE. I think majority of you must have noticed whenever you are raising a requisition, you click on CPOE. So that is computerized provider order entry system. So what would be an ideal situation? Ideal situation, as I said, EMR should come with clinical decision support system, and the whole hospital should be paperless, but it is easier said than done. However, there would be different stages of implication of EMR in all hospital, and as per WHO guidelines, they have divided those stages into 8 stages, starting from stage 0 to stage 7. So stage 7 would be ideal stage where the whole hospital is a paperless hospital. And where do we, so how this staging system work? Stage 0 is that we have some computerization, but we don't have all three major basic facilities, clinical, laboratory, and radiological on computer. When we have all these major ancillary clinical system on computer, then this is stage 1. When we could also access their report, it would be stage 2. When we can document all the vital flow charts, it would be stage 4. When CPO is incorporated, it is stage 4. And if we could this thing administer medication using this system, it would be stage 5. So where do we stand? Our hospital stands somewhere between stage 4 or 5. We have some component of stage 4 or 5. However, stage 3 is not fully operational in our hospital information system. So now coming to electronic health record. So what is the difference between electronic health record? So it is nothing but all the encounters which a person has with medical facility. These encounters not necessarily are because of disease or dysfunction. These could be just because of routine health checkup, master health checkup, vaccination, delivery, so on and so forth. So it is a longitudinal record of an individual of all the encounters he or she has with medical facility. Then on the same line, we have personal health record. So personal health record is somewhere a mix of electronic medical record and electronic health record, which could be understood by a lay person. Okay, and there are it could be maintained by a non-medical management system as well, and a person or his or her legal advisor can be guardian of those records. However, it is very important to note that these are not legal documents. It is for a person's own benefit or convenience they are maintaining personal health record. So as I was just mentioning that Health Assembly, held by World Health Organization in 2005, had advised all the member states that in today's era, we should make all the states should make an effort for e-governance, and there should be a e-health section under Ministry of Health. And our government has been doing that, and many of us are not knowing. Some of you are quite aware that they have already come out with guidelines of electronic health records, and those were published. In fact, that was second version published in 2016. So what is the ultimate aim of all this electronic health record, medical record, or personal record? That, as if you remember the first slide, that data is not only for the benefit of the patient. It serves so many purposes in planning, health planning, insurance, and so on and so forth. So if everything is computerized and on electronic platform, and if everything could be interoperable, then a data generated at one place could be utilized at national level, and that would ultimately help in e-governance. So that was all what I wanted to tell about medical record. And as I said, this regarding discharge summary, Professor Gaurav would be talking, and consent has already been covered in detail by Professor Kapoor. So I would briefly touch upon clinical audit. So what is clinical audit? Clinical audit is basically a quality improvement process that seeks to improve patient care and outcome through systemic review of care against explicit criteria and the implementation of change. So what we could review is, we could review anything: structure, process, and outcome. So what is utility of this clinical audit? It's a tool which can be used to discover how well a clinical care is being provided, and then to learn if there are opportunities for improvement. Like in this thing, I'm sure majority of the department SGPGI are doing annual audit, or some departments are even doing monthly audit. So basic intent is to improve patient care, and this could include a vast variety of or vast aspect of patient care area. And then we can implement changes, then we can again re-audit whether those changes were fruitful or not. So, but what is that is, you would be thinking that is utility to the hospital. What do I gain out of it? So we do gain something. What do we gain when we are involved in clinical audit? Then basic it basically offers to uphold professional standard, and we are also inclined to do the right thing, because as I said that in clinical audit you are comparing your practices against explicit criteria. So you would try to improve your practices, and then you would try to also identify whether there are any areas of risk, and take measure to improve or fulfill those gaps. Then regular audit activity helps to create a culture of quality improvement in the clinical setting, and clinical audit is educational for the participants. Why? Because like if I'm trying to audit this thing, I would go back and search what are the standards. So I would be educating myself, not only this thing for patients' benefit, it would also give me a job satisfaction if at the end of day I could see that whatever I had been doing is up to the mark. Like if in our department, we at the end of year, we like to see what was the complication of total thyroidectomy. So if suppose it is, there are two main complications associated with total thyroidectomy. One is permanent hypoparathyroidism, another is permanent recurrent laryngeal palsy. And if we see that our complication is less than 2%, and we know that by international standard, those are acceptable. So we feel happy about it, that we are doing a job which is at par with international standard. And if not, then we try to look where was the deficiency and try to improve it. So that is benefit of clinical audit. So then you would be saying you are we are investing so much time this thing, looking at the problem, implementing the change, and how it is different from research. So we need to know that research project focuses on discovering new information and exploring the best way to do the things. So what basically research is asking, what is the right thing to do and what is the best way to do it. Like if I go back to the example of thyroid, so for benign thyroid disorder, you could perform subtotal thyroidectomy or total. Research would ask whether subtotal is better or total is better. However, when you are performing audit, you would ask, are we doing the right thing and are we doing it the best way? So if research has already established that total thyroidectomy is the way forward, then we would see whether how many percentage of our patient underwent that particular procedure, and are we doing it the best way, whether our complications rate are similar to others or not. So that is basically basic difference between research and audit. So usually research is a one-time procedure. If you just this thing look at theoretically, so it is theory driven, but essentially at the end of it, the gain of any knowledge has to be translated to clinical practice. So we can't say that it is totally theory driven, but it is one time process, and it might involve an experimental treatment or placebo. On the other hand, as I said, audit is a cycle, because you try to identify the problem and then you try to rectify. Then after sometimes you again would assess whether improvement has taken place or not. So it's a continuous process, and whole department needs to be involved, or for that matter, depending on what we are auditing, whole management needs to be involved. Wherever on other hand, research could be done by selected people. So as I said, audit is a cycle. First you identify the issue or problem, then you set the criteria or define the standard, how we should be reviewing that data. Then we start collecting data, we compare our performance against criteria standard, and when we identify deficiency, we implement the changes. Then again, cycle begins. So at the end, I would like to conclude, or I need not to emphasize that medical records are integral part of medical profession. These records are important documents for doctor to patient and to society in general. As we discussed that they are not directly aid us in patient care, they also aid in medical legal cases, insurance, and health planning and budget. So, needless to say that maintaining and preserving them in a proper and methodical way is responsibility of ours. Thank you so much. I would, if time permits, I would be happy to take some questions. Thank you.